Right, thank you. Lovely to see everybody. And my name is Louise Soanes. I'm Chief Nurse here at Teenage Cancer Trust, and it's my honour to be chairing this webinar this evening. This is part of the London Global Cancer Week, and thank you to the organisers for allowing us this time to talk about adolescents and young adults with cancer. And the webinar is on the global initiatives in the care of adolescents and young adults with cancer. And it's hosted by World Child Cancer, and you can see their logo in the top right-hand corner of the slide, of the screen, sorry. So thank you, firstly, to World Child Cancer for hosting the event. World Child Cancer is a charity which works in 13 countries across Africa, Asia, and Central America, and they are committed to addressing the global inequalities in childhood cancer care and teenagers and increasingly young adult cancer care too. Their work falls into four main pillars: improving treatment for children with cancer, early diagnosis, direct family support, and advocacy. And they're very keen to have their work expand greater into adolescents and young adults, and which has hence led to this webinar today and our fantastic group of speakers. There are, as you've seen from the programme, for 3 presentations and a Q&A. So we've got great representation from across the world. You haven't come here to hear me witter on, so I'm just going to tell you a little bit about how the session will run, and then we will go to our first presentation. Firstly, before I do that, just to remind you, this session is being recorded, so people who have registered but can't attend can access this brilliant session, and also you can re-watch it. Each participant will share their own slides, so there may be a little bit of a waiting time while we do that, but bear with us. You can ask questions in the chat or in the Q&A. At the end of each speaker, we'll have a short period of time to ask and put some of those questions to speakers. If not, and you're a bit nervous or you want to wait a bit, there's also a longer period of time at the end of the session. Each speaker's got 12 minutes. Some people might overrun a little bit, some people might finish a little bit early, but that's time we've given them. So as I said, you can put questions in the Q&A or the chat. If you want to talk, if you want to put your question to one of the speakers, then just raise your hand and we can unmute you, but you can't unmute yourself. So once again, thank you so much for coming. Thank you for joining us. Please do ask questions. It's a great audience, great speakers, and we want this to be as interactive and for us to share and learn from each other. So without further ado, we've got slight change to the order of our speakers today, although you don't know what the order is, so it's not a surprise to you. So we are going to go to Italy first and speak to, join Dr. Chiara Ionio. Chiara is a psychologist and associate professor of psychology development and education at the Catholic University. She's got a special interest in young adults and children's mental health and well-being. And she's going to talk to us about childhood cancer risks for protective factors for adolescents' psychological and well-being. So thank you so much for being the first speaker. We're looking forward so much to what you're going to tell us today.
Thank you very much. And good evening, everyone. I am very honored to be here to give my speech, and I thank you very much for the opportunity to share my research in this occasion. I will share my slide. Okay, I think you can see it. Okay, thank you. And what I like to share today with you is an action research that I've been conducting with my team for some years now, together with Sole Terre Foundation in supporting children and adolescents with cancer and their parents. In particular, tonight, I will discuss data on the topic of risk and protective factors for adolescents' psychological well-being, adolescents that have suffered from cancer. As we know, adolescence is a time in a person's life when major changes are in a physical, intellectual, emotional, and social selves are experienced. Receiving a cancer diagnosis during this time of life can be extremely frightening, and as survival rates have increased, there has been a growing emphasis on the long-term effects of the illness and the process of long-term adaptation. One prominent issue that arises for teenagers with cancer diagnosis is connected to their body image. Literature, in particular, underlined how young patients do struggle with the side effects of treatment, including, for example, hair and eyelashes loss, scars after surgery, weight swings, and these factors threaten their sense of self and self-worth. This study is a part of a broader research carried out by the Trauma Research Unit of Università Cattolica di Milano with the collaboration of San Matteo Hospital in Pavia, together with Sole Terre Onlus Foundation. In particular, the aim of this study is to investigate the effect of oncological disease on body image in a sample of adolescents. The participants were 31 Italian adolescents with cancer. Our inclusion criteria were having cancer, have a good knowledge of Italian language, are aged between 11 and 18 years old, and that their parent allow us to perform, to submit the test to their son and daughter. We excluded from our sample adolescents who has psychiatric disorders. The research took place in Pavia from November 2019 and October 2021. So we catch also a very challenging period for the work in the hospital due to the COVID. And adolescents were asked to fill out some socio-demographic information. And in particular, they completed I Draw Myself drawing test. That is a qualitative tools that allow us to identify through drawing what adolescent thinks about themselves and their body. In particular, we can assess their body perception, attribution, satisfaction or dissatisfaction, and connected to various body districts. It's what we ask to adolescent is we ask you to try to represent yourself by drawing yourself as if you were to introduce to a person who is interested in you, but does not know you. You are free to portray yourself as you see fit, but try to communicate to the other person who you are and what are you characterized. Then we evaluate the drawings of our adolescents and through a scale that allows us to understand if which is their perception of their body. We also asked the adolescent to fill out the trauma symptom checklist scale to assess the presence of post-traumatic stress disorders and other symptoms. we find significant positive correlation between anxiety and the sexual characterization of the graphic representation of our adolescents. The ANOVA highlight a significant influence of the presence of dissociation on the sexual characterization and the influence of depression on the qualitative and the detail of their graphic representation. Here you can see some of the drawings of our adolescents, and the drawings are very poor. They didn't have a lot of contextual references, and the human figures is very primitive, and we can assess if the adolescent was a male or a female. So as you can see, there are no gender clue in these drawings. So from this result, we can underline that adolescents who face illness often experience feeling of anxiety and depression, along with dissociative symptoms relating to being hospitalized, according to a large body of research in the literature. Our result also seem to corroborate previous studies showing that young people with cancer find difficult to stay connected to their own body because of the invasive medical procedures they have to undergo. In particular, in the graphic representation of our adolescent, this translates into a lack of adherence to the real human figure. As you can see, the proportion and poor integration between the different parts of the body was very evident in their drawings. A lack of detail and information about face, body, clothing, and also a poor quality or the absence of representation of secondary sexual characteristics and details of the face and clothing that reflect gender affiliation. We can say from this first data that responses to chronic illness in individuals may occasionally become evident through the deployment of defense mechanisms. Using projective tools such as drawing, we can allow to emerge this defense mechanism, enabling individuals to express and externalize their experiences while circumventing the challenges associated with verbalizing their inner emotion. As a Solitaire Foundation is present in several countries around the world, the use of culture-free tools has allowed us to study the impact of childhood cancer in other population. We can see in a preliminary result of a first analysis. Sorry, but I have. Okay. So we start the same program that we had in Italy, also in Uganda, and we started with a sample of 41 adolescents, and our preliminary result underlined that also in this population, the drawing was very poor about the sexual characterization, and they don't have a lot of details and we found a positive correlation between adolescent sexual characterization of the drawing and depression, PTSD, and dissociation, as we found in the Italian sample. Here you can see some of the drawing we collected in Uganda. The strength of our study is that we can compare data from different countries using culture-free instrument. And this project also allows us to add some knowledge about the impact of mental health and psychological well-being on body image in young patients with cancer. The major limitation of this study is the small sample size, and we cannot generalize the result because we have a cross-sectional data, and we need more adolescents involved in this research. What we are doing now we are trying to extend the research in other contexts in which Solitaire is active, including Ivory Coast, Morocco, and Ukraine, and we are trying to collect more data as to compare and to let adolescents speak about their cancer experience and how this experience impact on their body image. Thank you for your attention, and I have finished my presentation.
Thank you so much. I think body image is such an important event or perception or concept for young adolescents with cancer. Can I ask a question? Was this measure done once, or was it done late in? Was it done during treatment or after treatment? Sorry.
For the moment, we do during treatment. We'd like to have to repeat the assessment also after treatment, and in different moments as to catch how being in different stage of treatment may impact of the body image, so we can also better understand if coming back to normality, to a normal life, can in some way help these adolescents to reconnect with their body and to feel the changes that the puberty can lead, and so on. So yes, we'd like to resubmit all the tests to see of treatment what's happened.
Yeah, I think that reconnection with yourself and your identity is so important. I'm just wondering if anybody else in the audience has a question, or anybody else from the panel has a question for Chiara. I'll hold the silence for a bit. If not, please do put your questions in the chat or in the Q&A, and as I said, we have another chance to talk about this really important issue of body image, self-identity, and also the impact of trauma on both those concepts of having cancer at this vital age. I've got one more question, if I can just ask it. The difference between the Italian adolescence drawing and the Ugandan adolescence drawing is quite different. Did you have any idea as to why that was?
But we start to think about these differences. I think that the Ugandan adolescents are more in contact with their body, and so they can represent themselves better than the Italian. And I think also that the hospital are different. The system of care is different, and so we are trying to compare also this data, because in Italy there is a very life sometimes stops for these adolescents. They stay in hospital a long period, and so they can express what the life of an adolescent. So I think that is also the different way they are in contact with their body, that is a cultural issue. And also, I think is a different hospital organization.
Okay, that's brilliant. Thank you so much again. And hopefully we'll have some more conversation about this towards the end of the session. Thank you so much.
Thank you. Bye.
Bye. So it's now my great pleasure to go all the way to Cameroon and introduce our next speaker, Dr. Francine Kouya. Dr. Kouya is a supervisor of clinical oncology in Cameroon at the Baptist Convention Health Services. She's got great interest in adolescents and young adults and how to better serve survivors of childhood cancer too. And Francine has spoken at one of our conferences in 2021, so it's a great pleasure to welcome her back to speaking to us. So Francine, are you there?
Yes, I'm there. Thank you. Good evening, everybody. Are you getting me?
I am. It's perfect. And the slides are just coming up now.
Okay, good. Thank you. So I'm really delighted to be here this evening and to talk about what is happening in Cameroon, with especially in Mbingo Baptist Hospital in the northwest region of Cameroon, the financial and family stress in this group of patients. So it's just a pilot study. We wanted to understand what is behind the science, what is behind abdominal distension, protrusion. We really want to understand the hidden face of the disease. Next slide, please. So Mbingo Baptist Hospital, as I said, it is in the northwest region of Cameroon, is the largest of 6 hospitals run by the Cameroon Baptist Convention Health Services. 60 years ago, it was a leprosy settlement. And now, because of the leprosy, because the number of patients with leprosy have reduced significantly, so now it is a referral teaching hospital with 350 beds. We have a 3 residency program. And our mission statement, it is exemplary care to all who need. This is really ambitious in a setting where we don't have any health insurance, in a setting where people have to go back to the village and contribute their money, sell their piece of land, and borrow money to be able to pay for the treatment of the relatives. Next slide, please. So what is happening as a background in Cameroon? Before 2003, it was only in the capital city, the only pediatric oncology center. Children have to travel with their family 2 or 3 days of traveling from the north of Cameroon, from the east-west, to go to the capital. In 2003, the second pediatric oncology unit that has been recognized by the Cameroon government has been opened in Mbingo Baptist Hospital. Those gray centers that you see, the gray color, are the satellite centers. Next slide, please. So, as a background, the diagnosis and treatment of cancer remains a significant cause of stress, not only for the adolescents, but also for the families. Jamal and collaborator in US find that 12,000 children are faced with significant stress associated with cancer diagnosis and treatment annually. What about Africa, in Cameroon? How much stress families and the adolescents are facing? So we are going to see what has happened here. So we decided we take our methods. We choose the adolescent, 15 to 24 years was our cutoff age. We recruited them during the treatment, during the follow-up, relapse, and phone call for those who have survived. And we administer to those 20 a design questionnaire to those who were speaking English. On the questionnaire, we also added the Beck's depression inventory, and the time frame was 1 month. Next slide. This is our result. The samples 20. Age means 18. Age range for this group of patients that we have for 15 to 21, and the gender was equal 50%, both men and females. I want to mention here, in Cameroon, when you are diagnosed with cancer, after your diagnosis is disclosed, the second thing is to discuss about the financial burden. How much is going to cost? Because if you don't do it upfrontly, it will be impossible for the family to take a solution. So the family needs to know how much the surgery is going to cost, how much the chemotherapy is going to cost, how much if there will be febrile neutropenia. So you have to give an approximate amount before the family go back and discuss together. Because usually family, because they don't have health insurance, family has to discuss it with the family head so that they come out with a solution. We look at these 20 adolescents that were interviewed. Where did your family got the funding? We look at the source of funding. 11% of the family, they have to sell what was important for them, a piece of land. 11% of the family, they have to borrow money. And 7% of the family, they have either they borrow money and they sold the land. They do the two things together. Why? Because some of the chemo, some of the treatment cost more than the other treatment. Example, maybe the family sold the land, and at the end the treatment was longer, and they did not have, and it was not sufficient. So they went back to the village to do a second action, either borrowing the money or either selling the land. Next slide, please. We look at the feeling so that let's understand a bit the feeling of this adolescent. We first took a group of orphans. The first orphan that we interviewed, she said, my uncle has paid already a lot of money. I am just afraid that he is going to stop their support because I lost my father while on treatment. And this patient lost her father 1 month ago, during a treatment. Another adolescent says, I am so angry with God for allowing me as an orphan to have cancer. Another adolescent feeling, after we disclosed the diagnosis and they gave the approximate cost of a treatment, she said, I couldn't sleep. I'm sad. Where is my father is going to get such amount of money? Because she knew from where she's coming. She knew that family cannot raise this amount of money. And another important thing, still that adolescent, because she has surgery. You know, when we give the interview, those are things that nobody would imagine that is going through the mind of this adolescent. She said, I am worried, doctor. I said, why are you worried? You know, one of my ovary was removed. Am I going to have children? These are the things that sometimes we don't pay attention, or we take them for granted that maybe the patient don't they are aware. She was not aware. And she said, you know, the other thing, I was lonely because I faced mockery. When my abdomen started increase in size, everybody thought that I was pregnant in my quarter. Another adolescent say, I feel punished with this cancer as my father did not finish to pay the bride price. So this adolescent, as he has the growth in his body, they started murmuring in the family. It is because the father has never completed the bride price of the mother. They have first to go back to the village, carry out all the tradition before he came to the hospital to receive his treatment. Another adolescent was so sad and said, you know, I'm feeling guilty. My mother has abandoned my brothers, her business, to be here stuck in the hospital because of me. Next slide. We look at the effect of the family. We are talking about toxicity, financial toxicity. And I think that financial toxicity is worse than even drug toxicity. We have seen what is happening. The family has to go sell the land, the only property that they have, maybe for many generations. We look at the effect on the family, especially on the sibling. 50% of the family, they were okay. Maybe it's because of the number of the was just small. 35% of the sibling have to stop school because all the money was used for one person for his treatment. One adolescent told me, my brothers and my sister have to wait for 2 years before they clear all the debts, so that we should think about education again. This is because of cancer. These siblings, they are affected. Their education are destroyed. Their future is hijacked because of cancer. Next slide. We look at the total score, the score level of depression. This is the scale that we use. From 1 to 10 was just up and down. So 11 to 16, mild mood disturbance. 17 to 20, border clinical depression. From 21 to 30, moderate depression. 31 to 40, severe depression. Over 40, extreme depression. Next slide. Good enough, we didn't have extreme depression. We don't know whether because that sample was just a small sample. These are the type of malignancy that we were having. We have Burkitt lymphoma. Most of the patient, most of our cohort was Burkitt lymphoma. And we see also here that some of the adolescents, they already have disease of the adults. There are the 2 cases of choriocarcinoma that we have. Next slide. Okay, so we look at the depression category. How many of them were normal up and down? About 50%. We look at now the moderate depression and the borderline depression. There were 7 of these adolescents with these symptoms of depression. Next slide. We say, let's look at the level of depression by patient characteristic. We look at the patient and the household income. The first group, household income less than 50,000 per month. Do they have depression? Yes, we see borderline clinical depression. We see moderate depression. We look at the monthly income depression, monthly income greater than 100,000. You look at it, you see that they didn't really have, we don't really see, except mild mood disorder, but they were not really depression. Of course, a child that is coming from a very poor background, who knows that their family, they have to struggle, they have to sell everything for them. Of course, they will be more depressed. They will have extra depression compared to those whose family, they don't really struggle financially. We decided to look at the level of education, whether primary, secondary, university. We see more depression with the secondary education. And I noticed in my practice, those who are in the secondary school, they say, I'm writing my A-level. I don't want to miss this year. I'm writing my O-level. Because this group of patients, the government set up a date of their exam. And if you miss the June exam, there's no opportunity. You miss that year. But some those who are in university, they usually have a second option. They have the first option is in June, and the second one that they can catch up maybe in September. So that is a speculation that we thought. Next slide, please. In conclusion, there is stress, anxiety, and mood disorder. It crosses beyond the color of the skin, beyond culture, even financial background. It is really important that we clinicians, that we should think about, we should recognize these signs and symptoms so that we can help teenagers to cope. Anxiety and stress related to cancer can occur even long after the treatment has ended. We talk about those families where the sibling could not go to school. Also, imagine that you are an adolescent. They spend all the family income, and your brothers, your siblings are not going to school for 2 years. I'm sure that probably the guilt will continue to follow them. Healthcare provider should be trained to identify mood disorder so that patient gets screened and treated appropriately. Next slide. Bold and proud, a sign of encouragement. So when adolescents are coming to the hospital because I also shave my hair, this is because I have alopecia due from age. So now everybody now is bold. They're happy when we are talking about alopecia. When I'm talking about side effects, I'm starting with alopecia and say, like, look at the way that I am. This is it. So they feel encouraged, and sometimes we take the picture to show who has the best bold heads. Thank you.
Thank you so much. That was brilliant. I loved the pictures at the end. We still have no questions, people. You're going to have to get chatty, or else I'll come and find and might call on some familiar names in the participants. Francine, can I ask you a question? I think your presentation really demonstrated the impact on the whole family of a young adolescent having cancer. Could you tell us a little bit about the support network that's available to those families in Cameroon? You spoke at the end about training healthcare professionals, and I know World Child Cancer has worked with you on initiatives. I wonder if you could tell us a little bit more about how people are supported during their cancer in Cameroon.
So yeah, in my hospital, what we have some funding. Anyhow, the funding that are really officially available is for children less than 15 years, and also curable disease like Burkitt lymphoma, Wilms tumor, retinoblastoma, Burkitt lymphoma. So now from 15 years to and above, they don't usually have a how they call it, an official support. But sometimes we have drugs that are available, and then those drugs are coming when we see that the family is exhausted, and that is maybe a case, maybe an early disease, and they have a chance to survive. Those are the ones that we can really help. So sometimes also we have a social worker, we have the chaplaincy department, we have also a parents' home where we allow the adolescent to be in our parents' home so that the family don't have to look for extra money to pay where they are going to stay while they are on treatment. And my hospital does not have a psychologist or psychiatrist, so usually it's still the fourth front line clinician that are supposed to screen those patients, and it's becoming too much. Sometimes we miss those information or those signs.
Sorry, that would help if I'm off mute. Thank you so much for that answer. And it does sound as though the support around the young person, and we've got a sort of a question that sort of builds on that in the Q&A from Bob Little. And Bob's asking, can the hospital have a supporting mechanism or psychologist to talk to the kids and their guardians? And you spoke about social workers, and I didn't know whether you had access to a psychologist in your hospital. Ooh. Francine, are you still there? Did you hear my question?
I'm still there. Yes, thank you. We don't have a site. The hospital will employ the workforce that they can pay, so they will not pay extra maybe for a psychologist or a psychiatrist. So we use the chaplain sometimes, the chaplaincy department. We have a chaplain assigned to the pediatric unit and the adolescent unit. So sometimes they are helping us to understand whether the family issues, crisis around the diagnosis. So sometimes they are helpful, but they are not also trained for that. They're just using whatever they have, but they are not trained for that.
Brilliant. Thank you so much. And I think there's certainly a theme, as you guys can see in this webinar about psychology and well-being and psychological support. So we'll probably pick that up. And Francine, there's a lovely comment in the webinar chat about your presentation, which I'll let you read while and others can read, while I introduce our third speaker. So thank you so much for your presentation, Francine. So our third speaker is in Canada. I'm not quite sure what time it is over there. Dr. Sumit Gupta, who's known to many of you on this call, I'm sure. Sumit is a staff oncologist and clinician investigator at the Hospital for Sick Children and chair of PERCC, which I hope the pronounce that's, which is Policy and Economic Research in Childhood Cancer. So it's great to have you with us, and we'll let you talk to us about symptoms in AYA cancer diagnosis and the risk of short and long-term mental health events. So picking up on many of the themes we've raised today. So thank you so much.
Thanks very much, Louise. You can hear me okay?
Oh gosh, yes, all good.
Perfect.
And the
Okay, well,
slides are perfect.
Thank you, everyone, for the invitation to join this wonderful panel and for coming to be part of this session to our audience members. So as you can see, there's a bit of a theme running through the presentations today. So I'm going to pick that up and just talk a little bit about some of our experience here in Ontario and some of the research we've done. So as you've probably been convinced of, hopefully by the previous two presentations, we know that adolescents and young adults are at risk of adverse mental health outcomes, both during and if they survive after their cancer treatment. And work that we did looking at some younger AYA here in Ontario showed that their risk of severe psychiatric episodes, which we defined as an episode involving a hospitalization or emergency room visit, was quite a bit higher than that of AYA who hadn't received cancer therapy, or a cancer diagnosis, I should say, represented by the blue versus the red lines here. And so knowing that this population is high risk, what we thought, and what we and many others have thought would be very helpful, is that if we had tools to identify of the whole population of AYA, which are highest risk individuals for an adverse mental health outcome, either during or after cancer treatment. Because, you know, as noted by Francine and by many others, we don't have unlimited resources. And so guiding both screening and interventions to those AYA at highest risk would be a very useful thing. So given that, we really tried to determine whether patient-reported symptoms, so this is where, you know, you have some formal way of asking a patient themselves about what their symptom burden is, whether that type of system was associated with both short and long-term severe mental health events, which we'll talk about over the next couple of slides. So just by way of introduction, for those who aren't familiar, so, you know, I'm sitting here in Ontario, Canada, which is one of the 10 provinces here, has a population of around 15, maybe 16, 17 million people now. It's quite a demographically diverse population. It's a very high immigrant, first-generation immigrant, second-generation immigrant population. So many, many different races and ethnicities represented in our population. Unfortunately, we do not have a structured AYA cancer healthcare system in Ontario. There are multiple initiatives that individual oncologists or individual institutions have, but there's not a provincial, specifically AYA cancer system, unlike, say, in the UK or in Australia. We are lucky enough to have a universal health insurance system here. Now, because of that universal health insurance system, though, we actually have a large number of population-based healthcare databases. So there's a database, for example, that captures every hospitalization in our population, every emergency room visit in our population, all outpatient physician billings. And that's mainly because these are the type of records that are needed for administration. So, you know, every time I, as an Ontario citizen, goes to see my family doctor bills that visit to the government in order for that family doctor to get paid. And so all of these data and these records are out there, and there is thankfully an infrastructure here in Ontario where those records are linked individually and anonymized and then made available to researchers like myself to be able to ask and hopefully answer important clinical or policy questions. So what we did then is assemble a cohort of all adolescents and young adults in Ontario who were diagnosed with cancer between the age of 15 and 29 in the time period between 2010 and 2018. And that's using our provincial cancer registry that we have here in Ontario, and we're lucky that that's quite a high quality registry. And then that whole cohort of Ontario AYA, we then linked into these healthcare databases, emergency room visits, hospitalizations, outpatient visits, et cetera, and ICS is the name of the institute that that keeps all of these databases for research use. So our main outcome was a severe mental health event in any of these patients, which we defined again as any emergency room visit or hospitalization for a mental health related reason. And we looked at both short-term severe mental health events and long-term severe mental health events. And in a slide or two, I'll define what we mean by those. The main exposure we were interested in was patient-reported symptom burden. And the way we measured this was through a score that many people will be familiar with, the Edmonton Symptom Assessment System, or ESAS. And that's a validated patient-reported measure of 9 cancer-associated symptoms. And each of those symptoms, patients are asked to grade from 0 to 10 in terms of severity. And then those numeric scores are usually categorized as either not measured because the patient didn't answer, versus none, versus mild, versus moderate, versus severe. And in 2010, the government here in Ontario introduced a program to administer and capture ESAS scores to all patients attending cancer outpatient clinics. So theoretically, every time a cancer patient goes to their outpatient visit, they are either handed a form or an iPad or some other method. They get asked about these 9 symptoms, and they put in their rating of that symptoms. And not only does that go to their clinical team, but a copy of that gets linked into the administrative databases that I mentioned. Now that's theoretically true. We and others have shown that, it is somewhat variable who gets asked, and then it's somewhat variable who actually answers. So even though we theoretically have that on a whole population, it's not like with completeness that every patient answers these questions every time they go to a clinic. This is what the paper form looks like, and so you can see pain, fatigue, drowsiness, nausea, et cetera, et cetera. So remember, the 2 outcomes we're interested in here are short-term severe mental health events and long-term severe mental health events. And from a symptom point of view, we're really interested in anxiety, depression, and poor well-being in terms of the 3 symptoms on that ESAS list of 9 that were most indicative of mental health from our point of view. And we were interested in the severity of those 3 symptoms in the first year after their cancer diagnosis. And we conceptualized the ESAS score, or the symptom severity, as something we call time varying, means that it changes over time, right? The symptom that a patient may have had at one time point is not the same as the next time point. And so just as an example, let's take this initial patient who theoretically is diagnosed with cancer. Now, say they don't actually report their symptoms at the beginning using an ESAS score. So then they start off with being categorized as not measured. But say a couple of months in, they actually say, hey, my anxiety is at a level of 2 now. Well, okay, now we have a sense that they have mild anxiety because they rated it as a 2. So now they're categorized as mild. But then say a couple of weeks later, they characterize their anxiety as a 5. Now they get recategorized as moderate anxiety. And then after 30 days, if they haven't rated their anxiety again, they go back to non-measured. And then say later they rate their anxiety at 8. Now they're severe, and then they never rate it again. So after 30 days, it goes back to non-measured. So you can see this is sort of the way we have a trajectory built for each patient, where they get categorized within one state to another state, but that may change over time. And then we used some statistical analyses to look at the association between those states and then subsequently having a severe mental health event. and we adjusted for all sorts of demographic and cancer variables. So one set of analyses was concentrating on short-term severe mental health events, but then the next set of analyses were concentrated on looking at long-term severe mental health events. And so for this, we restricted the cohort to only those who had survived 5 years from their initial cancer diagnosis. And then we looked at their cumulative incidence of these severe mental health events, starting at that 5-year point. So waiting 5 years and then following them forward to seeing if they had a severe mental health hospitalization or emergency room visit. And for this, we were just interested in the maximum ESAS score, so the most severe ESAS score they had in the first year of diagnosis. So taking that initial theoretical patient from the last slide that we talked about, their maximum score would have been 8 or severe. So this patient would have been categorized as having experienced a maximum of severe anxiety in that first year. And then we jump ahead 5 years from their initial cancer diagnosis and then follow them forward to see whether they had a severe mental health event or not. Okay, so that was the setup of the study. So what did we find? So our total cohort comprised of about 5,400 AYA. The median age at the time of their cancer diagnosis was 12, and blood cancers, or I should say hematologic cancers like leukemia and lymphoma, were the most common, representing about a third of the diagnoses in this cohort. And we found that symptom severity was indeed associated with subsequent risk of short-term severe mental health events. So, for example, compared to those that were reporting mild anxiety, those reporting severe anxiety were fourfold more likely to have a severe mental health event, i.e. end up in the emergency room or be hospitalized for a mental health reason. This wasn't really that surprising, right? This is what we were expecting to find. And we found similar findings, for example, when we looked at depression. Severe depression or endorsing severe depression was associated with a 4 times more likelihood of subsequently ending up in the emergency room or the hospitalization for mental health reasons. What we were a bit more surprised by was looking at our long-term severe mental health results. So once we restricted to 5-year survivors, that brought it down to 3,500. That number of 65% seems low when you first think about it for an AYA high income country cohort, but it's because, remember, this cohort went to 2018. So at the time of the analysis, a lot of them actually hadn't had 5 years since their initial diagnosis. So this doesn't mean that only 65% survived, but we just had follow-up to 5 years of in about 3,500 patients. And we found that symptom severity in that first year was also associated with long-term severe mental health events. So, for example, starting at 5 years post-cancer diagnosis, the subsequent 3-year cumulative incidence of a hospitalization or emergency room for a mental health reason among those supporting severe depression in the first year after their diagnosis was 12%, whereas if you had only reported mild depression in that first year after your cancer diagnosis, then you only had a 2.4% chance of, from year 5 onward, another 3 years, ending up in the emergency room or in being hospitalized for mental health reasons. So this was actually surprising to us to see this much of a difference, because again, there's a 4-year lag between when these patients were reporting their anxiety, their depression, their well-being, and when we started looking at long-term mental health long-term severe mental health events. But nonetheless, what their experience was and what their perception of their own symptom burden was in that first year still had a very significant association with their long-term risk of severe mental health events. And these are just the cumulative incidence curves, and you can see that brown is those who report severe depression rather in the first year, all the way down to the red, which is those who reported mild depression only. And there were similar results for anxiety and poor well-being. So, in summary, a very simple patient-reported symptom score identifies a subgroup of adolescents and young adults with cancer that are at high risk of both short-term and, somewhat surprisingly, even long-term severe mental health events. So that raises the question that should those subgroups be more intensively screened, right? So if you check off that you have moderate to severe depression, should you be more intensively screened, not only for the duration of your cancer treatment, whatever's left of that, but also going forward into your survivorship as well? And then the really big question is, will interventions either during the cancer treatment or after the cancer treatment that we target to these high-risk subgroups help mitigate their risk? Can you avoid them ending up in the emergency room or being hospitalized? I'm going to skip this for the sake of time. Next slide. So in terms of future directions, we're currently conducting some sensitivity analyses. We're also linking to records of various referrals. So, if that patient that reported severe depression got referred to social work or psychology, does that actually help mitigate their short or long-term risk? And hopefully experts listening who are psycho-oncology experts, unlike myself, might be interested in an intervention trial, for example. And then finally, just a few thoughts about how this applies or doesn't apply to low middle income country AYA. So, despite some very inspiring individual initiatives that some of which we've heard about today, AYA cancer is still neglected as a field in most low middle income countries. And very little is known about mental health during or after AYA cancer treatment in low middle income countries. The two examples you heard today from Cameroon, from Italy and Uganda specifically, are really amazing exceptions, but I think they are, examples in a very sparse field because this hasn't been a major focus. But, one wonders whether low middle income countries that are just starting to build AYA programs or AYA initiatives can avoid the mistakes of high income countries by building in mental health as an essential part of these AYA programs, even as they're being established. And I think both what we've heard about happening in Uganda and Cameroon are sort of really good examples of teams and individuals that are doing that already. So I just want to thank my collaborators and my research team and some other folks and our funders, and then I'm happy to take questions either now or at the end.
Sumit, thank you so much. We've got time for one question. I think the question that you asked at the end of your slide will bring back to when we bring the whole panel together, if that's okay. But there's one question in the Q&A for you. It says, dear Sumit Gupta, are there any other ways or being developed that exist or being developed other than a survey for self-rating the levels of anxiety and depression in adolescents and young adults?
So I think, in the field of patient-reported outcome measures, and, I'm a health services researcher, I would not call myself a patient-reported outcomes expert. There are lots of people who are experts in that. I think the key, though, is to make it simple and accessible to patients. So, I might not even think about it as a survey. I might think about it even just as a simple question. And whether you're asking that in a paper form or whether you are asking that or making sure that a clinician asks that, whether that's the nurse in clinic, the oncologist in clinic, a psychosocial worker in clinic, I think as long as there's a way to ensure that that is happening systematically and regularly for patients, I think that's really the key. I will say some of the feedback we get from patients in Ontario a ton is that, okay, I answered this the first 2 times and nothing really happened, so why am I bothering answering it again? So I think that's the other key there, is that, it's no point in asking unless you're actually going to do something about it if patients or symptoms, whether that's the nausea or whether it's mental health related symptoms like anxiety and depression.
Brilliant. Thank you so much. I'm going to move on now, if that's okay. As I said, we'll bring the panel all together at the end for a panel Q&A, so hold those questions. But now, it's my pleasure to invite 2 people onto the screen who are going to have a conversation with each other. So the first of those person is Prince Nyamadi, and apologies if I mispronounce your name, Prince. Is a chartered cancer survivor and a biomedical scientist. He's also a co-founder of Living Dreams Foundation. And his ambition is for every child suffering with cancer, especially those in Africa, to receive the best care and support they deserve. And Joining him in the conversation is Megan Cruz, who is Psychosocial Support Advisor for World Child Cancer. So thank you both so much for waiting patiently. I'm handing it over to you. I mean, we're in your hands now, so far away.
Thank you, Louise. Thank you so much, Prince, for joining us today. It's really great to have you here to talk to us about your experience. Prince and I have known each other for about six years now. We've worked very closely together through World Child Cancer's work in Ghana. So thank you, Prince. So Prince, can we just begin with you telling us a little bit about yourself, please?
Right. Thank you so much for having me. It's always a pleasure. And as you rightly said, it has always been interesting to have a chat with you. So basically, I'm Prince Nyamadi, a childhood cancer survivor. However, I fall in the age bracket of childhood adolescent cancer survivor group. And so I think it's always a pleasure being here. I'm a biomedical scientist, a co-founder of Living Dreams Foundation. Yeah, thank you.
Great. So, Prince, can we just tell us a little bit about some of the challenges that you faced throughout your childhood cancer diagnosis and treatments?
All right, so thank you. I think I remember I was diagnosed at the age of between 10 and then 11. So I could vividly remember everything that happened back then. And some of the challenges I faced undergoing treatment were, first of all, I could remember the fear of death, because the treatment was so vigorous and was so intense. And then looking at, the whole hospital setting, because I think that was my very first time I could remember going to a huge hospital. It was a teaching hospital. So, looking at people, the diseases people were carrying, some were physical, so you could see. And then going to the oncology ward, you could see some with retinoblastoma, a bigger, eye, some having been amputated, some having swollen, then lymphomas and all that. I was having this, fear of death. The second thing I would like to talk about is loss of hope for the future. Because looking at some kids coming on the ward with that bulgy eye, I was thinking, how could this child, even after surviving this condition, go out there and fight for what he or she wants to become in future? So I was a bit skeptical with mine, even though mine was acute lymphoblastic leukemia. I was a bit skeptical because I felt, even after treatment, is there hope for me? Is there possibilities? Because, during the treatment, I have to stop school for some time. And so, I was a bit not too okay, thinking of probably the future. Again, what I would like to talk about, some physical effects due to fatigue, pains, throughout the treatment, side effects from treatment, where I had bowed head, that was alopecia, nothing, no hair on my head, going to school where they're living in a community with, a sakura head. In Ghana, we call it sakura, and all that. How to put on baseball cap or hat anytime I'm going out, of my house on confinement. Was something that I was really battling with. And then changes of mood as well. My mood wasn't that stable because of the pain and anxiety, the fatigue I was going through. I wasn't most often happy. I was always, being the sad child, always in the family, in the family and, in the house. Okay. And again, isolation due to compromised immune system and extended hospital stays. Isolation is something that every childhood cancer patient would face, because you are most often in the hospital receiving treatment, or even after treatment, you are in the house, isolated, because, you would have some side effect of maybe the chemotherapy or whichever treatment you are going through, maybe vomiting, maybe not feeling too well, and mood swings and all that. So somehow, somewhere you'll be isolated. And if you don't really have a supporting family to always be by your side, you feel neglected. And so I think these are some few challenges I faced, as a child, undergoing treatment.
Thank you, Prince. And then you mentioned your family. Then can you tell us a bit more about the impact it had on your family, and also including that the impact it had on your siblings?
Yeah, thank you so much. So for my family, this had a huge impact, both my family and my siblings as well, because it brought, there was gap in the family bonding, because growing up as a child or among my siblings, together with my parents, you could, growing up without cancer, you could see that bonding between our parents and then the siblings. Obviously a child needs to be nurtured and all that. So there was some bonding between us. We sometimes in the evening eat together. In the morning, you could see my dad ironing our dress, getting us prepared for school. My mom doing the dishes, preparing food for us, going to school. So there was some form of bonding growing up. However, when I was diagnosed with cancer, that bond, broke apart. I should say, because they had to spend so much time on me, taking me to the hospital, ensuring that I'm okay, ensuring that I take my drugs, my medications. You could see that there wasn't that bonding again, because, and again, my siblings also had some form of pity for me, because they understood the situation or the condition in which I was. And so there wasn't that family bonding any longer. And then again, I remember vividly about financial burden as well, where majority of the money my parents make would have to be channeled for buying off my medications. And talking about financial burden and cost of drugs, we only focus on the drugs, forgetting about the diagnostics. Okay, so when I say financial burden as a on parents, what I mean is that aside, mobilizing money to buy drugs, for my medications, I should say, another aspect we have to look at is the diagnostics. What I mean by diagnostics is the cost for my labs, the x-rays, the CT scans, and even accommodation. Because if you live far away from the hospital and you need to probably go on some period of treatment, meaning that you have to relocate and live closer to the hospital or inside the hospital. And that is cost, because you need to rent a place, to be able to be closer, for the treatment. And again, looking at food, you need to buy food for yourself as a parent, you need to buy food for the child. And because of the child's condition, the child needs some specific food, nutritious food, to be able to, move along with the treatment the child is going through. Okay, so financial burden was something huge on my parents. I could remember my mom is a businesswoman actually, and so every profits she made out of her business was just channeled into my treatment. My dad was also into health, and so you could see that anytime he receives his salary, he just brings it to the hospital, forgetting about my siblings, because then my siblings were also in school, and so they need to pay school fees for them, buy some books and all that. And you could see that I was taking chunk of the money for my parents. And so it was something that was huge on my parents. Secondly, I would like to talk about the change in family dynamics, where we could sometimes have a family get together, during Christmas. They take us out, for some fun games, buying stuff for us. All those things changed. And so the dynamics in the family, I should say, came to a halt. Okay, and then stress on my parents, because my parents had to focus on their business. It was no more. All the focus was just on me. Okay, and then potential changes in employment and business as well. My dad was a government worker, and my mom owned her own business. However, because of this condition, they couldn't focus more on their businesses, because basically that was what was raising the money for them. And for you not to focus on your business means that there will be some depreciations in profit making. Okay, and so these are just some few examples I could remember that had a big toll on my parents. Okay, talking of my siblings, as I said earlier on, that sibling bonding was no more, because most of the time I just felt to be alone because of what I was going through. I didn't want people to be around me because I didn't have that interest of talking to people. Okay, so even though my siblings were willing to come closer to me, I felt I had to just be alone by myself and just rest and just sleep. Okay, and then again, that social bonding, what I mean by social bonding is because growing up, your siblings could come to you. You guys could play together. You guys could read together. You guys could discuss, stuff together. It was no more, and so I not that I felt, not that they made me felt neglected, but myself I felt to be neglected somehow, because I felt, I should be by myself and then face whatever that I'm facing to, so that they could also have their life of their own. Okay, and then I have to add this, stigmatization was something that I was really, really facing, not from my parents but from the society, because most of them didn't know much about the condition. It was something that I was really fighting. Even though my parents and siblings were fighting so much for me, I believe that, it was due to lack of awareness, okay, and then education of the public that raised that, stigmatization to that level. And so I believe that with time, which, we are fighting really, that, in the years to come, the society and a lot of people or the general public would know much about childhood cancers, and then they could also relate, whenever they see a child, battling with this condition.
Thank you so much. I think there's time for just one more question that I'd like to ask you, Prince. So, as an adolescent and young adult going through the cancer diagnosis and treatment, the impact it had on your mental health, which you've very openly shared with us, what support would you have liked to access during that time?
All right, thank you so much. So growing up in Ghana, that was in the year, I was diagnosed in the year 2002. And so what I would love then was to have a psychosocial advisor or a psychologist, okay? Because I believe that as a child being diagnosed of cancer, the impact is not just on the child, it's on the parents, the impact is on the family, it's on their siblings, and even anyone around the child, okay? And so that was one thing that we really lacked, and I think it's something that has to be inculcated or or should be adapted in our hospital centers. And I'm really glad it has always been mentioned throughout all the presentation that, psychologist is very important in our hospital setting, not just the hospital as a whole, but specifically when it comes to oncology wards or childhood cancer wards. Okay, because, just imagine growing up being diagnosed of cancer, my parents are informed that your child has cancer, or a parent is informed that the child has cancer. And then what next? You have to bring money to treat your child. All right. And just imagine somebody who doesn't really understand what the condition is, or probably the person is an illiterate, let me put it, or not really informed. Okay. There and there, trust me, so many parents will just abolish the treatment. They'll just abandon it, because they even don't understand why a child who has basically done nothing, okay, not to sin and nothing, just been diagnosed of this horrible disease. All right. So then there to just break the parents and be like, okay. And then again, looking at the financial aspect as well, bringing all this money just on a child, whilst I have 3 or 4 other siblings. No, I wouldn't spend that money on that child alone. What I would do is let that child die, and so that I could use the money to, take care of the other siblings. It's better off, honestly speaking. Let truth be told, if you have 3 other siblings and just spending your whole money selling your properties to just cure one out of the 4, no, you wouldn't do that, even as a parent. So we need a psychologist around to let them the parents understand. And the sad part of it is that because people are not well informed, they even don't know that as a child having cancer, you could even survive the condition or the disease. All right, that is another aspect of it. So if we have a psychologist to sit our parents down to let them understand that, first of all, a child even having cancer, there are so many hopes for him or her, even if there are so many hopes for her if he or she survives the disease. All right. And then look at me now. What if my parents neglected me in the hospital and I died? Today I'm a biomedical scientist, and they are so proud of me, or, even as a child. And so you could see that yes, there is positive, result as well, not just the negative part of it. Okay. And then secondly, if they, as a child, if the psychologist makes me understand that this is just a phase of your life, all right, and so you are not going to die out of this condition or out of this situation. And so if you are able to go through the treatment, it's possible, and 199 percentage that you could come out of this condition and even become a better person of yourself. All right. And so I think it's very, very, very key, having a psychologist around, where whichever institution it is, especially focusing on childhood cancer treatment wherever in the world. I know in the western part of the world, yes, there are programs and there are units like that, but back in Africa, no. I haven't seen one yet. I'm hoping that pretty soon we would have psychologists around. Yeah.
Thank you so much, Prince. Thank you. It's a pleasure to talk with you, as it always is. And I just wanted to also take a moment to thank you for all the work, the incredible work that you do for children with cancer and survivors in Ghana, through obviously World Child Cancer, but also through your own organisation, the Living Dreams Foundation. So thank you very much.
Thank you so much. Thank you so much for having me. It's always a pleasure.
Thank you so much. Prince and Megan, are you happy if we include your questions in the panel, or would you? Nothing has come in specifically, but I think if we, unless anybody's put their hand up, which I haven't seen. So shall we go, if the rest of the panelists could turn their cameras off, that'd be awesome. Thank you, Sumit. So we have been literally around the world. We've been to Italy, you heard from Uganda, Ghana, Cameroon, Canada, and I'm in London. I'm sorry, it's very noisy traffic out there at the moment. So if you hear any noise, that's why. And I think we've really been around the world. And I think there's lots of people on this call, but I'm going to put one question to the panelist, and it was from Sumit's last slide, really, and picking up on what all the speakers have spoken about. And Prince, when you talked about what you would want to see for young people and children with cancer in Ghana, in the UK, we've had an adolescent and young adult cancer service since 1990, and young people are still telling us today that the care for their mental health is not as good as the care for their physical health, and the access to psychologists, social workers, other sort of mental health support workers is not great. So we haven't got it right, even though we've been doing it for 33 years. So I suppose the question to the panelists and to the audience really is, how can we build mental health support at a level that's appropriate to the country and the health system that it's in, as AYA cancer programs are established? I don't know if anybody wants to take that first. So how do we make this work from the word go, I suppose? And we're still thinking about how our services are established, even though they're 33 years old. So we haven't got it right. But I don't know if anybody else had any thoughts about how we could start that.
I mean, I guess I don't know, I'll replace your question with another question, I suppose. I think the challenge is, I think, how do we make psychosocial support thought of in the same ways we think of the chemotherapy and the antibiotics, right? Like, no one would try to start a cancer center without chemotherapy, without antibiotics, without nurses. And I think the challenge is for those of us who know that, you could even make the argument that particularly in the middle-income countries where abandonment is a bigger problem and such, that psychosocial support, you could argue, is even more crucial than in high-income countries. And so I think the challenge for us as a community is to be consistent in our messaging, that you cannot have a well-functioning childhood or AYA cancer center without chemotherapy, without nurses, without oncologists, or without psychosocial support or staff. It just has to be part of the essential ingredients, and we should be talking about in the same breath as all the other parts of a cancer center.
Yeah. Anybody else want to? I agree. We say that, but it's.
I agree with Sumit. I think that we have to have a more global idea of health, because we think that health is only physical health, and mental health is always neglect in the care of the patients. So I think that we need to have a wider idea of what health is, and so also the care we give to the patients is greater if we take into account both physical and psychological, social health.
Yeah, thank you so much. I also think from a survivor's point of view, as you rightly said, it's not just about the physical treatment, but the mental health as well. Even looking at the short-term and then long-term effects of the treatment, especially the long-term, as a survivor, what I still face is mood swings, changes of mood, because sometimes not that anybody has really offended me, but I just feel sad, and I'm pretty sure it's based on my experience in the past. Okay. And then secondly, what I face is anxiety, because I don't know, but I always feel anxious about things that I'm not supposed to be anxious about. Okay. And then thirdly, I would like to talk about the fear of the cancer coming back, because sometimes as human as we are, there are little illnesses that we would face, as life moves on, maybe a slight headache, maybe fatigue, and any other conditions as well. But anytime these conditions pop up, the first thing that comes into mind is the cancer coming back. That is what comes, because those were some of the symptoms I felt when I was diagnosed with cancer. So anytime I have headache, I have stomach problem, I feel is the cancer coming back, So I believe, it shouldn't just end in the hospital. However, in the long term part of this journey, there should be a designated, psychologist that we could always speak to, and the psychologist also checking up on us to feel how we're doing. And then again, we should have like a coach or a mentor that could also help us, in the future, because let's not forget that we've missed a lot, especially even in our education, our social life. We spend so much in the hospital, and so we've made some chunk of our life, outside the hospital. And so there should be like a coach or a mentor that would even guide us in our career choices, in the future, so that it would best be known that, oh, since you've been through this condition, I think you should rather go into this profession or that profession. And I think that would help you a lot. And again, looking at job search as well, most jobs or most works that we have don't really even consider survivors. We are all in the same bracket. Whether a job opening, we all apply. They don't really care whether you've been through this condition or that condition. We all go through the same aptitude test, the same interview and all that. And even some of them, if you tell them you're a survivor, and so there are some form of deficiency, they don't even really care about that. And so there should be some form of I should say some form of I don't even know how to put it now. But you know, they should make some room, a little room for us, you know, to help survivors as well. So it's very, very important that we have psychosocial, you know, advisors around us any day and any time. Thank you.
I thank you so much. I think it's beautifully said that it's a lifelong thing, isn't it? And it's how the support grows with you and moves with you as you go through your adulthood. I don't think anybody has got that right, but I think it's something that we as healthcare professionals, charities like World Child Cancer, Teenage Cancer Trust could advocate, and governments and cancer plans could think, as you said, as Sumit said, you know, you wouldn't think about, you know, again, assessing for physical sign impacts of chemotherapy. So we should build this as part, as not even parallel, but embedded in AYA and childhood cancer programs. Francine, you've been very patient. You've got your hand up.
Okay. Thank you for giving me the floor. I think that's one thing that I also want to add here, as what I've seen, for example, in HIV program, there were some of the counseling where maybe HIV patient themselves, or I don't know, yeah. So using, for example, the power of the survivors, maybe as social worker, as mentor, truly, I think that this is something that can really help, because, you know, as Prince is describing, we can only maybe, they are the only one to really know the depth of what has happened. I just want to take the example of alopecia. You know, in my hospital, all the children were having a cap. They couldn't remove it. But since I've shaved my hair, you know, we put our head together and we see who has the best bald head. And, you know, it has demystified that issue. So children are coming and the parents are not more covering their heads, but they are covering their head when they are outside. Because, you know, people don't understand why this child is like this. There's something wrong with this child. Is this something mystic or some? So I think that the first thing that we have to do is that we can use the power of the survivors as mentor, and also share their stories, because stories has power behind them. And also communication, you know, if we healthcare provider, we are so busy focusing on signs and symptom, temperature. When do we ever have time to answer who is the head of this family? You know, it has happened that we are like in my hospital, you are doing everything. The head of the family is not there. The day of surgery, and you know, in my culture, a woman has no power to decide that the child has an amputation or an enucleation. The day of surgery, the father is coming from nowhere and say, I don't want the surgery. And when we inquire, we recognize that the information that we gave to the mother, now she go and pass to the husband. Maybe she go and pass only 10%. So I think that I think that communication really matter. If we communicate properly to the family, I'm sure that some of those adolescents, they will be able to carry the burden better.
I completely agree. And it's, you know, childhood cancer, adolescent, young adult cancer, it's, you know, it's having that support with you, having that family with you, significant other with you through that. It's about caring for the whole of the holistic system, isn't it? But I think, so because we're running out of time now, I think, Megan, have you got enough to sort of build? This webinar was about how World Child Cancer could focus on adolescents. We've naturally come to a theme of psychological support, mental well-being, mental health. I think we've heard of initiatives and measures across the world. I think we've heard of Prince's thoughts about what it's like on the long term, and we've heard how to advocate for mental health at the same time as you would for physical health. And the last thing, which I've completely, but which is just Francine's fault, is about how we can engage the people who know this best, i.e. the people who've been through it. So has that given you some food for thought? Have you got, and I know this was a conversation and to have a conversation, but
Yes, it's given
What
us
can we all take away from this, I think, is some of those great things that we've heard in the last 90 minutes and some of the conversation we've had in the last 5 minutes.
I agree. It's given us a wealth of information, incredibly helpful, and from all different dynamics as well. I think it's been super helpful. So thank you all very much for taking the time to be here and to share your experience and all your expertise and knowledge with us. We're very grateful, and it will certainly feed into World Child Cancer's work, because we're hoping to develop our services more towards adolescents and young adults. So this will certainly help a great deal towards that work. So thank you very much.
So it's 7:30, well, my time. I'm not quite sure what time it is, but people, Prince, I'm sure you've got things to do and go back to work and start your evening, have some supper. I thank to all the audience. Thank you for everybody who joined. Please keep the conversation going. World Child Cancer is available on, and all the speakers are available. Their work is available on the internet and things like that. So keep in touch. Thanks to Megan and all the team at World Child Cancer for setting this up and for supporting us during this particular webinar. I will let you go about your day. Thank you so much, and thanks again. Take care, everybody. Take care. Bye. Bye.
Thank you, everyone.
Bye.